All right, let's dive into the adrenal glands. Think of them as your body's little stress management command center. We're going to look at what happens when that system goes haywire, leading to two conditions that are polar opposites. Cushing's, where there's way too much hormone, and Addison's, where there's not nearly enough. Getting a grip on these two extremes is absolutely essential for your nursing practice. So let's get into it.
So the big question is, what really happens when the hormones designed to keep you stable suddenly decide to rebel? In this explainer, we're going to see how one patient can be literally swimming in cortisol while another is left in a dangerous deficit. It's truly a tale of two extremes, and we are going to break it all down for you.
Okay, here's our game plan for today. First, we'll meet the key hormones, the major players in this story. Then we'll get into the nitty-gritty of what causes Cushing's versus Addison's and what they look like in a patient. From there, we'll talk about your nursing priorities, what to do when a crisis hits, and finally, the patient teaching that can literally save a life. First things first, let's get to know the hormones themselves. You can't understand the problem if you don't understand the power players involved. This is the foundation for everything else we're going to talk about. Okay, so here are our two main characters. First up is cortisol. The easiest way to remember it, think stress and sugar. It manages your metabolism, especially glucose, handles your body's stress response, and also kind of tamps down your immune system. Then you've got aldosterone. Think salt and water. It tells your kidneys, hey, hold on to sodium and water, but get rid of potassium. Burn those two roles into your brain. It's going to make understanding the lab values so much easier later on. All right, so now that we know what the hormones do, let's jump into section 2 and figure out why they go off the rails. Where the problem starts is really what defines the difference between Cushing's and Addison's. So if you remember one thing, remember this. They are complete opposites. Cushing's is hypercortisolism. It's a state of excess, just too much cortisol. Addison's disease, it's the mirror image. It's hypocortisolism, a deficit. The body is starved for both cortisol and aldosterone. One is a flood, the other is a drought. Simple as that. So this slide gets to the why. For Cushing's, the cause can be endogenous, meaning it's coming from inside the body, like a tumor on the pituitary or adrenal gland. But honestly, it's way more common for it to be exogenous, meaning it comes from an outside source. And the number one culprit is long-term use of steroid medications like prednisone. For Addison's, the main cause is usually an autoimmune problem where the body attacks itself. But a huge secondary cause, and one you will see all the time, is when a patient abruptly stops taking those same steroid medications. That's a huge red flag. All right, now we're getting to the core of what you do as a nurse, assessment. How in the world do you tell these two apart when a patient is in front of you? Let's look at the clues you'll find, both at the bedside and in the lab reports. I want you to picture your two patients right next to each other. Your Cushing's patient is going to have that classic central weight gain or truncal obesity, that round moon face, super thin skin that bruises easily, and those purplish stretch marks or striae. Their blood pressure, probably sky high. Now look at your Addison's patient. They're the total opposite. They're losing weight, they have this really unique bronze-like tan or hyperpigmentation, and they get dizzy when they stand up because of orthostatic hypotension. Now, what's interesting is they both might complain of weakness and fatigue, but the rest of the clinical picture couldn't be more different. And the labs, well, they tell the exact same story of opposites. In Cushing's, remember, that excess aldosterone makes the body hoard sodium and dump potassium, and the excess cortisol cranks up blood sugar. So you get high sodium, low potassium, and hyperglycemia. In Addison's, without those hormones, the body can't hold on to sodium, so it drops. But it holds on to potassium, so that goes up. And blood sugar, it plummets. So you see low sodium, high potassium, and hypoglycemia. It's a perfect mirror image. Okay, time for a quick check-in. Let's put this to the test. Your colleague Matt is looking at the labs for his patient Annie, who has Cushing's. Based on everything we just covered, what should he expect to find? Go ahead, take a second, and think it through. Did you pick increased sodium, increased blood glucose, and decreased lymphocytes? If you did, you nailed it. The high sodium is from that aldosterone effect. The high glucose is a direct result of too much cortisol. And remember how cortisol suppresses the immune system? Well, that's why we see a drop in lymphocytes, which puts this patient at a huge risk for infection. And that leads us perfectly into our next section, your priority nursing actions. You've done your assessment, you've looked at the labs. Now, what do you do? What's the first move?
For your Cushing's patient, everything is about managing the consequences of too much. Priority 1 is safety. All that cortisol leaches calcium from their bones, making them super brittle. You have to prevent fractures. Priority 2, prevent infection. Their immune system is weakened, so you have to be obsessive about hand hygiene and monitoring for any signs of infection. And third, you have to watch for hypervolemia, fluid overload. That means daily weights, strict INOs, and looking for things like edema or distended neck veins.
For your Addison's patient, the priorities are all about fixing the not enough, and it's much more urgent. Your number one job is to prevent circulatory shock. They are losing fluid like crazy, so you're going to be pushing saline infusions to restore that volume. At the same exact time, you have to deal with that life-threatening high potassium, so get them on a cardiac monitor and manage their dangerously low blood sugar. Okay, let's put on our critical thinking caps. Back to our patient Annie with Cushing's. She's experiencing weight gain, fatigue, has fragile skin, and joint pain. Out of all of those, which one is your absolute top priority? The answer is A, weight gain. And here's why. While all those other things are problems, rapid weight gain is a massive red flag for fluid overload, hypervolemia. That fluid isn't just uncomfortable, it can lead to severe hypertension, heart failure, and pulmonary edema. It's the one finding on that list that can spiral into a cardiovascular crisis, and fast. And speaking of crisis, let's talk about what happens when things go from bad to worse. With both of these conditions, you have to be constantly on the lookout for a sudden, life-threatening emergency. The one that everyone fears is the Addisonian crisis, or acute adrenal insufficiency. Make no mistake, this is a true medical emergency. It's what happens when the body is hit with a major stressor, like surgery, trauma, or a bad infection. And its demand for cortisol skyrockets, but the adrenal glands just can't keep up. If you don't intervene immediately, the outcome is, well, it's not good. Your response here has to be fast, and it has to be automatic. Step 1, and this is the most important, replace the hormone they're missing. You're going to give an IV bolus of hydrocortisone. At the same time, you're restoring their fluid volume with rapid saline infusions to pull them out of shock. Then you're tackling those electrolyte messes, the high potassium and low glucose. And finally, get them lying down with their legs elevated to help their blood pressure. These actions are life-saving. Now, you might be thinking a crisis is only an Addison's problem, but that's a dangerous mistake to make. A patient with Cushing's can absolutely have an adrenal crisis too. It usually happens after surgery to remove a tumor, or, and here it is again, if they suddenly stop their steroid medication. Their body has gotten used to those crazy high levels of cortisol, so when it's suddenly taken away, they crash into a deficit. And the treatment is the same. They need glucocorticoids stat. And that brings us to our final, and I'd argue, most important section. Your job isn't over when the patient is stable. Lifelong patient education is the single most powerful tool we have to empower them to manage their condition and stay out of the hospital. These are the non-negotiables. This is your patient's survival guide. Number 1, drilled into their head, you never, ever stop taking steroid medication suddenly. 2, they have to wear a medical alert bracelet. 3, they need to know that when they get sick or under a lot of stress, they need to call their provider because their dose will probably need to be increased. And for our Addison's patients, they absolutely must have an emergency kit with injectable hydrocortisone and know exactly how to use it. This education is their lifeline. So I want to leave you with this thought. As their nurse, you are the person standing right in that gap between a fragile hormonal balance and a full-blown, life-threatening crisis. So the real question isn't just what you'll do when the alarm bells go off. It's how are you going to use this knowledge to see the signs, to connect the dots, and to anticipate what your patient needs before that crisis ever has a chance to begin. That is what makes a great nurse.